Hello, my name is Sanjay Jain. I'm a fourth-year medical student at the University of Buffalo, and today I'm going to be talking to you about a case involving cervical angina versus angina pectoris. So the patient involved here is a 55-year-old African-American male um, who had reports of a chief complaint of sudden onset chest pain. So the patient states that that morning he had been starting to have retrosternal tightness, sharp chest pain starting early in the morning, which he rated as a 6 out of 10. This pain was well localized to the retrosternal area without radiation elsewhere. Reported no nausea, shortness of breath, any diaphoresis, and reported that this chest pain felt similar to a previous NSTEMI episode he had had in 2008. Which was treated with a 4-vessel cabbage procedure. The patient noted there was mild improvement of the pain by leaning forward and worsening of the pain while walking. He had taken his usual medications that morning, but that did not relieve his pain. He also reported that the left upper extremity pain that he was experiencing was similar to the same type and character of pain that he had following a vehicular accident noted in the paragraph below. And this left upper extremity pain will be discussed later in the case in terms of differential diagnosis between angina pectoris, acute coronary syndrome, and cervical angina and cervical radiculopathy. So previously, this patient also has a recent history of a motor vehicle collision. He reports that he was a belted driver of a vehicle that was stopped and was struck from behind by another driver, and he felt a snap in the neck from this collision. While he reported no loss of consciousness, he did have immediate neck pain and went to Buffalo General Hospital where he received a CT scan and was discharged, only being prescribed ibuprofen for his pain. Afterwards, however, the patient did report that he felt that the pain was like a torch on the back of his neck and to his shoulder as well. He also had associated middle and lower back pain. He reported that after the accident, he started having 3 to 4 headache episodes a day, with associated dizziness and blurry vision, but denied any nausea, photophobia, or loss of bowel or bladder control. His sleep also decreased from only 8 hours a day to only 2 or 3 hours a night, and also denied any fever, chills, loss of appetite, weight change, low energy, anxiety, or night sweats. This patient also has a past medical history of coronary artery disease, rheumatoid arthritis, hypertension, and hepatitis C. He denies having any previous work episodes, any previous vehicular accidents, or any slips, falls, or athletic episodes affecting either his neck or back. As noted earlier, he did have a surgical history including a 4-vessel cabbage procedure, and also right hand surgery due to his progressing rheumatoid arthritis, and as well as a bilateral hip replacement. As far as medications, he is currently taking Crestor, Plavix, and also medication for his rheumatoid arthritis as prescribed by his primary physician. On physical exam, the patient had a blood pressure of 118/80, did not appear any acute distress, alert, oriented ×3. Heart had a regular rate and rhythm, normal S1, S2 with a slight systolic murmur, 2+ bilateral radial pulses. Lungs were clear to auscultation bilaterally, no rhesus rails or bronchi. And on his musculoskeletal exam, had significant limited movement in the cervical spine. Left rotation was only 30 degrees, right rotation also 30 degrees, flexion of 39 degrees, extension of 7 degrees, left lateral bending of 4 degrees with reproducible pain to arm, and right lateral bending of 7 degrees. And all of these motions had reproducible neck pain radiating to the shoulders. Reflexes were in the biceps and bilaterally it was 2 plus reflexes in the triceps bilaterally. On cervical compression, neck pain and pain to left shoulder. With left rotation, it's pain to the shoulder. Left lateral rotation, pain down, extending to the left elbow. And with combined movements of left lateral bending, left rotation extension, reported pain extending all the way from neck to left forearm. Muscle strength in both biceps and triceps bilaterally was 5 out of 5. These first set of images were taken after his motor vehicle accident. The first image shows an MRI between C3 and C4. Here you can see that there is no spinal impingement at this level, but somewhat narrowing of the spinal canal, but no foraminal narrowing at this level. Notice a mid to upper cervical pseudoblock vertebrae. Moving down to MRI of showing C5 and C6. There's a little bit more of a mild disc bulge with the effacement of the anterior CSF and mild central stenosis, again relating to this disc bulge, with protrusion herniation and congenital small spinal canal. And going down further to C6 and C7, again there is an even more prominent disc bulge with, again, effacement of the anterior CSF, and again the spinal canal is somewhat narrowed. And this image does show mild foraminal narrowing bilaterally. The patient did receive coronary catheterization, and coronary angiogram imaging was taken. This image here shows catheter in the left circumflex artery, and as you can see there is a stent placed proximally, and when contrast dye is injected you can see a very significant occlusion in this left circumflex, which was noted at 99% occluded, meaning that this entire vessel has been occluded. And here we have again some still images from the coronary angiogram that was done. Here is shown as the left anterior descending artery, and above you can see the stent from the left circumflex. The left anterior descending is shown to be patent and actually has been previously anastomosed to the left internal mammary artery from the previous CABG procedure. And again, this image here again shows the left circumflex artery with prominent occlusion here in the proximal region, which has been 99% occluded. This next image shows the left internal mammary artery, which again I noted has been anastomosed to the left anterior descending artery and provides blood flow to it now. And this artery is continuing to be shown as patent and continuing to provide blood flow to the heart. The next image here is of the right coronary artery vein graft. As you can see here, there is a narrowing in the proximal region of this vein graft. This narrowing was noted to be about 80% stenosed, and therefore a catheter was placed in order to widen the stenosis. This next image shows that a catheter, shown here by these radiotracers in the catheter, has been placed into the right coronary artery and widened with balloon angioplasty. The next image shows that after the balloon angioplasty is done and stent placement, right coronary artery now is fully patent, no longer has stenosis, but more distally to this artery, it was noted that there was some filling defects going distally into this artery, and as you can see here, from either plaque buildup or probable dissection of the vein graft. Again, balloon angioplasty and thrombectomy was attempted to be performed. They were unable to take out any thrombus and proceeded to add another stent distally to this right coronary artery, and this image is shown to be fully patent with TMMI3 blood flow. And again, this image shows without contrast that a stent has been placed here approximately in this right coronary artery vein graft, and then 2 stents actually placed distally in order to resolve the filling defect that was happening distally in the right coronary artery. As a follow-up to the patient's inpatient procedure of coronary catheterization and having 3 stents placed in the right coronary artery, a nuclear medicine myocardial stress test was done, and in this image shown kind of a polar map which shows kind of globally uptake in the heart. As you can see, there is no reversible ischemia from stressed or rest state, meaning that these areas are pretty much irreversible ischemia. In this next image, it's shown the distribution, the coronary artery distributions into the heart are noted, and as you can see, as mentioned before, in the left circumflex artery, which is 99% stenosed and completely occluded, there is complete irreversible ischemia here. In the right coronary artery, where 3 stents were placed and there was an 80% stenosis, there's a large amount of irreversible ischemia present, but it still has some uptake of the radionuclear dye. And the left anterior descending artery, which was shown to be patent and still connected to the left internal mammary artery, still shown to have good perfusion in the scan. An ejection fraction was also noted on this nuclear imaging myocardial stress test, and ejection fraction of 29% was noted. This was later correlated with a nuclear Muga scan, which again showed only about a left ventricular ejection fraction of about 30%. In this last image from the nuclear medicine myocardial stress test, it shows slices, images of the heart in 3 different views. The short axis goes from the apex to the base of the heart. Again, vertical view going from the septum all the way to lateral walls, and then again a horizontal view going from inferior to anterior side. And all of these views diffusely, you can see that there is a large fixed deficit in the lateral wall as well as inferior wall, again from previous myocardial infarctions and occlusions to left circumflex artery and right coronary artery. As noted earlier, the patient reported chest pain, but also reported that he had left upper extremity pain that was the same type and character he had following his vehicular accident, as was noted earlier. So based on his past history of both CABG procedure and previous coronary artery disease, but as well as a motor vehicle accident that has caused significant changes in all the way from C3 to C7 levels of his spine. Our differential diagnosis included both cervical angina, otherwise known as pseudoangina, which can come from either trauma or disease to the cervical spine, where pinching of these spinal nerves can produce both left arm pain, neck pain, but can also manifest as chest pain due to the nerves innervating the muscles, such as pectoralis major, pectoralis minor, in that area of the chest around the heart. While the other differential diagnosis was angina pectoris from acute coronary syndrome, as again he's had previous CABG procedure, previous coronary artery disease, and noted that the chest pain also did seem similar to the previous NSTEMI episode that he had had back in 2008. In this case, however, with any kind of chest pain, cardiac causes must be ruled out first. However, given his history and again noted factors of rheumatoid arthritis, cervical angina and cervical radiculopathy were also on the differential, but would be ruled out after running through cardiac tests. The first of which he received was coronary catheterization, which did reveal occlusion of the left circumflex, and again severe stenosis of the proximal vein graft of the coronary artery. And this was treated with stents to drug-eluting stents to both the proximal and distal right coronary artery, which successfully introduced flow back into that artery. Currently, this patient is stable and has significantly reduced chest pain. However, on physical exams, he noted he's still having pain in his neck and pain down his left arm that was reproducible on exam. However, the patient is ambulatory and seems to not have any difficulty doing his normal activities, and as mentioned previously, is not having any kind of cardiac pain or any other kind of chest pain, but continues to have lingering pain in the neck and left arm, most likely due to, again, his previous motor vehicle accident. In conclusion, cervical angina is a diagnosis that needs a high index of suspicion. As any kind of chest pain, again, cardiac causes need to be ruled out first, but as any cardiac cause is ruled out, if the patient has risk factors of previous neck injury, arthritis, or any of those kind of radiculopathy symptoms, cervical angina should be on a differential diagnosis for a physician, and usually can relatively be treated conservatively with hard collars, intermittent traction, isometric exercise, chiropractic care, and usually a combination of just anti-inflammatory and muscle relaxant medication.